Good afternoon, everyone, and welcome to the Systems and Sustainability Echo brought to you by BWell Texas. My name is Shreya Prasanna, and I will be facilitating our discussion today. Some housekeeping before we get started. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate the bottom of your Zoom window and select the Show Captions option. We are recording these sessions for later distribution through the BWell YouTube channel. Any info you put in the chat will not be shared in the recording. As always, please stay muted unless you are speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We encourage everyone to join by video for the discussion portion of our sessions. That said, regardless of how you've shown up today, we're just as happy you're here to learn alongside us and share your perspectives in today's discussion. Please, because there are a lot of us here, we ask you to keep your comments brief to allow space for others to speak up as well. You can also use the chat feature to raise questions and comments. Please note that no predicted health information is allowed in either the chat or our discussions, and that includes name, emails, exact dates, or any other information that can easily identify an individual. To help us with attendance, please enter your name, affiliation, and email into the chat feature. To all the BWell Texas providers, please make sure you identify yourselves during this session, or if you're joining via phone, please email your phone number and email and name to bwelltx@utisca.edu. Towards the end of the session, we will send out a link to an evaluation survey. Please fill it out to be entered into a drawing for a $30 Walmart gift card. Our didactic today is on From Trauma Curious to Trauma Informed and will be presented by Dr. Bryan Hatcher. After that, we will follow up with some announcements from the BWell program and then hear a systems case from our learning community. As always, I encourage you all to share your questions, feedback, and guidance for the questions raised by our case presenter today. Remember, we're all teachers and all learners in this space. And with that, we will move on to some introductions. Matt.
Hi, folks. Excuse me. I'm Matt Rosa. It's good to meet you. It's good to see all of you today. My background's in clinical social work, also agency administration, governmental planning, and I work as a consultant in quality improvement, as well as implementation science in health and human services. Thanks for being with us.
Thank you so much. Leslie.
Hi, everybody. I'm Leslie Manson. I'm a licensed clinical psychologist. I'm also a consultant related to integrating substance use, mental and behavioral health, and medical care treatments. My background is in healthcare leadership, financing, and I'm an associate professor at Arizona State University. Thank you.
Thank you so much for joining us. Darlene.
Good afternoon, everyone. It's nice to be with you all. My name is Darlene Calona Byler. My background is I'm a licensed clinical social worker, and my background is in integrated healthcare and policy. It's nice to be with you all, and I am a senior vice president for specialty healthcare with the Beddoes Mental Health Policy Institute.
Thank you so much for joining us. Kathy.
Hello, everyone. Good to see everybody. I'm a consultant who specializes in integrated care, putting substance use, mental health, and healthcare together. I also specialize in healthcare policy and leadership development.
Thank you so much. Dr. Hatcher.
Bryan Hatcher. I have a background in social work, more recently public health. I'm the vice president of behavioral health at Yakima Valley Farm Workers Clinic, a large community health center covering the states of Washington and Oregon.
Thank you so much for joining us today. Chelsea.
Good afternoon, everyone. My name is Chelsea Collier. I'm a woman in long-term recovery. I am also the Prosper Project Coordinator with Recovery People. Recovery People is a statewide recovery community organization offering advocacy, training, and research, and all good things. So I'm glad to be here. Thank you.
Thank you so much for joining us today. Andrea Hebler.
Hello, everyone. My name is Andrea Hebler, and I'm one of the program coordinators here at the Center for Substance Use Training and Telementoring, CSTAT. Very happy to be here.
Thank you so much. And with that, we will move on to our didactics. Dr. Hatcher, whenever you're ready, and Jackie will please share the slides.
Okay. While the slides are coming up, just let me say a word of appreciation to you all for letting me be part of this conversation, particularly my good friend, Dr. Kathy Hudgens. We've worked together and appreciated life with each other for many years, and I'm glad she's part of your work as well. Yeah.
Thank you.
So yeah, in front of you there, you see the title, where we're going. I would add, in terms of my current role here in the Pacific Northwest, I've been here only about a year. As you all may discern, as soon as I start talking up here, people start looking at me and saying, "You're not from around here, are you?" So I spent the previous 25, 30 years in North Carolina working at Academic Medical Center there in behavioral health. So next slide, please. Disclosures, I have none to disclose. So, next slide. For this presentation, I thought through what would be helpful to know about trauma-informed care in the space that you all are working through, and my research, particularly around implementing trauma-informed care into behavioral health organizations. And first, I decided you all would want to know, why am I the person to do this beyond just an academic interest? So as I mentioned earlier, I have about a 25-year history of providing direct behavioral health services and providing leadership to organizations in that space. As part of my personal journey, several years ago, I became very interested in how do we get to a place where we can help individuals, families, communities actually not need our behavioral health services. I believe that is sustainable. Let's just do prevention work and create a healthier space for people to be. Hence the public health interest that said public health continually says, push it upline further and further and further. Let's get to the place where we don't have illness to have to treat. I had been introduced along the way to the ACEs study. Those of you who are not aware, that was done back in the 90s when that publication came out. There were about 17,000 patients who were many more, but who completed the course of the research over several years, indicating that for a particular set of adverse experiences in childhood, such as living in poverty, living with a single family, living with someone who's abusive, etc., there are particular health outcomes that can be predicted. So when I decided to go back to do my doctoral work a few years ago, I wanted to focus on ACEs. Well, it didn't take but about 10 minutes to realize that the event of adverse experiences in one's life absolutely has a health income impact. You can take most health issue that you want to look at, reverse engineer that to childhood for patients who struggle with that, and find some connection. We didn't need to prove that again. We know that information. So I was curious, what do we actually do? So I actually spent my time looking at what is the strongest way to implement trauma-informed care as a response to managing ACEs. I wanted to do in healthcare in general. You know how this research thing goes. The more specific it can get, there it is. So we focused on implementing into behavioral health settings. A personal story which really drove this process for me. I grew up in a small mill village in North Georgia. And, that was way before the time of cell phones and internet and all of that. So cartoons got old after a while. So we were all outside playing. My house was the house where we had a basketball goal and a large field on one end of it. And so all the kids gathered there. It was not unusual. Most any day after school, weekends, whatever, there were a crowd of us around. One particular day, we were out in the field behind the house playing football, and it was approaching 5 o'clock. And there was one of our friends in that group that day who we all knew. His dad ran a pretty strict household. His mother had died early in his life, and his dad was raising this son by himself, doing the best he could. And he had some pretty adamant rules, one of which was 5 o'clock, everybody is at the dinner table. Well, on this particular day, about 5:05, my friend had just lost track of time as we were having a good, enjoying ourselves outside. His dad walked straight down the street into the middle of our football field, grabbed my friend by the shirt collar, dotted his I, drug him home. We didn't see him again for 2 weeks. Fast forward, my friend died in his late 50s, just a few years ago, from complications of alcoholism and diabetes. He had been through multiple marriages and himself was the single father of 3 children when he passed away. To me, that's the outcome of adverse childhood experiences. So that personal story and others that we all could tell really is what has driven my professional career and where I am today with all of this. So with that background, let's move to the next slide. So the first question, of course, is what is trauma-informed care? While I have spent more time in school than most people need to, I often get frustrated by those processes. And as I was working on this, my doctoral committee kept asking, what is trauma-informed care? What do you do? They wanted it to be a treatment protocol that you taught providers how to do. And I kept backing them up saying it's not that, it's a culture that gets created in an organization. And for the life of them, they just weren't open to understanding what organizational culture meant. So I dug deeper and deeper and deeper. I finally landed on this definition, which I believe is a good overview of what it is. So it's really a service delivery approach. If you've ever been to Disney, you know that they have a customer service approach. So think of it in that way. It does entail some clinical processes, if you will, some work on trauma specifically by providers, but it actually has as much to do with how a person is greeted at the front desk, how individuals who work in the organization treat each other, et cetera. And it's often driven by policy. So it really is a state of culture in an organization where members of that organization have an understanding that most all of us have some trauma history, and the organization builds structures to minimize the physical, mental, and behavioral impacts on that trauma based on our organizational behaviors. So if you're in a trauma-informed organization, we assume that's kind of what's happening. Next slide, please. So you may have noticed from the title, I actually started with trauma curious, but when I'm looking at the phases of implementation of awareness, if you will, of trauma-informed care in an organization, we started with trauma aware. I take this from trauma-informed Oregon. Oregon was one of the first states to declare itself a trauma-informed state. And by that, they meant any social service organization receiving state funds, i.e. if you're getting Medicaid, then you will become a trauma-informed organization. So these stages are taken from their their work, and you can follow the references to find more information about that. But I actually add one at the beginning, which is trauma curious, and that being that before awareness occurs in an organization, there usually are one or two, a handful of folks who are just curious about this phenomenon. That certainly was my experience. For my friend in North Georgia, I have wondered many times how not just that day when his dad showed up in the middle of our ball game, but how his life really drove the way that things played out for him. So someone has a curiosity about that. From that, there often then becomes a scenario where enough folks in the organization begin to talk about it. They have an awareness that this has happened. They probably have gone to an ACES conference or seen a presentation on that. And they're able to start explaining, well, we already do some things, and advocate for trauma-informed care to become the norm of the organization. Next, we move to a sense that there's a sensitivity to it. So the awareness builds that trauma-informed care is needed in the organization, and staff begin actually creating the structures of readiness for that change. I use Prochaska's change model, if you will. And if we back up to the trauma curious piece, that would be sort of the bridge between pre-contemplation and contemplation for the organization. So then trauma aware and then trauma sensitive. Next slide. Back up one. So after trauma aware, we become trauma responsive. So we're not fully informed yet as an organization, but we begin to notice ways that things are already happening, and we start taking opportunities to notice policies and practices that can be changed and actually start moving toward changing some of those things. Usually senior leadership is bought in, if not driving the process at this time. And the organization is feeling pretty good about where it wants to go. And somewhere in the trauma responsive state have decided, made not just personal decisions, but an organizational decision, usually at the senior leadership board level, to actually become a formal trauma-informed organization. And then finally, as a trauma-informed organization, policies and practices are in place, and they are specifically designed to create this culture of trauma-informed practice, which promotes safety, empowerment, trust, et cetera. And those elements, the safety, power, empowerment, trust, and others, are easily found through SAMHSA. If you go to the SAMHSA website, they have a whole trauma-informed area that you can look into there. So those are the stages of sort of, as an organization is moving toward becoming trauma-informed, that we would notice that an organization goes through. Next slide. So just deciding that you want to do this, if you're the CEO and advising your policymakers to make it happen, is not really all there is to to this process. So as part of my research, I actually interviewed 43 organizations that had gone through the process to become trauma informed. Interviewed a provider, an administrative staff person, and a senior leadership person in each of those organizations about their learnings through that process. And these next pieces are the themes that came out of that understanding. The first, and everybody was absolutely clear about this, leadership buy-in is critical to the success of implementing trauma-informed care. If senior leadership is not bought in, and that doesn't mean just lip service, they actually believe it, they're living it, they're breathing it, we roll our sleeves up, we get into it with them, that is going to be the make or break element to this happening. So I had many folks say, if your CEO is not fully bought in, just don't do it, because it will flounder, it will come up short. Second, you need a very clear and common understanding of what we mean by trauma-informed care in the organization and a model from which you're going to work out of. There are lots of models out there that you can adopt. Most folks will take 2 or 3 of those models and evolve it into one that really fits their organization. Setting this up to be successful for your staff, that the uptake of this is something that they can actually succeed in and is not overwhelming to them, does not feel like just one more thing they have to do, which means it's not just a task. It really is something that everybody in the organization has an understanding of, not just intellectually, but existentially as well, and can relate to it likely from their own story, and they want this to be the case. Next slide. The policies then serve as the foundation for the organization to become trauma informed. They actually drive all the practice that's there. And these are not just clinical workflows or policies, but these are all of the HR policies, all of the billing practices, et cetera, that need to be worked through from a trauma-informed lens. This next bullet point really caught my attention during the interviews for the research, and that is trauma-informed care and fee-for-service funding schemes. If you see one client for therapy, bill an insurance company and get paid for that session, that model is very difficult to sustain trauma-informed care, because trauma-informed care will actually reduce the amount of sessions provided, if you will, because it also trauma-informed care requires us to do things like have group sessions to process difficult scenarios and that sort of thing. And fee-for-service funding has dropped significantly over the years. They actually have taken the candy company's model for reducing what you get, and they haven't necessarily dropped fees, but they have stopped raising fees. So we do more and more. The cost of our business goes up and up. Our what we're paid doesn't. But there are models that can work with trauma-informed care, particularly the value-based stuff, the pay for performance versus pay for volume. Those kind of models work well with trauma-informed, and partnering with the payers to do this work goes a long way, because your outcomes will be so different. To launch trauma-informed care, moving to the next bullet point, it is absolutely advised that you seek external funding. This can be a grant of some sort, or other means. If sometimes there's a pool of money internally that can be dedicated to this, but to help people get up to speed, take time out of clinical work, which drives revenue, to do this, you want that upfront funding. And then if you have the capacity to negotiate with your payers to move away from the fee-for-service to the value-based or pay-for-performance kind of payment models, then sustainability is absolutely there. Data should be the primary driver of operational clinical decisions, and the bigger the data, the better. Which is interesting, because for me, this was driven by one story of one day, one afternoon, playing with my friends in the backyard. Sometimes an N of one is powerful, but to understand trauma-informed care and population health sort of go hand in hand, and to understand the needs of what individuals need on a larger scale, we need to be looking at data to drive those decisions. Next slide. So once we've gone through the process of becoming trauma informed, once we have worked through all of those hurdles to make us successful, what's the point? You all are about sustainability. I love the title of this ECHO group. So it's there. So why do this other than it's good for our patients? Well, we also learned, this was almost a a positive secondary outcome, it's almost just as good for our staff as well. So employee retention and turnover, both of those get better. We retain folks longer. We turn over less often in organizations that are truly trauma informed. That is the case over and over and again. Absenteeism goes way down, and employee wellness goes way up. The number of sick days taken drops off because folks just feel better and actually want to come to work because it's such a positive environment. Parallel to that, employee satisfaction goes up. Most organizations of any size now have an employee satisfaction or employee engagement survey that's done pretty regularly, and we see these scores rise pretty drastically in organizations that are successfully trauma-informed. For our patients, appointment completion goes up, meaning no-shows reduce. They're here, they feel valued, they feel welcomed. It helps them to engage in their care even better. Likewise, their performance outside the clinic, at school, their academic performance, their work performance, attendance goes up, their grades get better, et cetera, et cetera. It also improves their adherence to programs that they're involved in. That can be a clinical treatment plan, their school activities, their extracurricular activities actually as well. Folks are involved in sports or other events, those things improve if they are receiving significant care inside a trauma-informed environment. And then finally, along with those things, the patient or client, however you refer to them, their satisfaction goes up as well. So much like we do with employee engagement surveys, most organizations have patient satisfaction surveys, and these tend to improve the scores there as well. I believe the next slide is references, so that covers what the data that I wanted to give to you, the information. So we're there, and I'll pause there and let the facilitators of the meeting take over. I know there's going to be conversation in a bit, so I look forward to that.
Thank you so much, Dr. Hatcher, for a wonderful presentation. I now open up the floor for any questions or comments with Dr. Hatcher.
Silence means it was either so good there aren't any questions, or well, I don't even know what he was talking about, so I don't know how to ask a question.
Well, I do have a question now.
Okay.
Like how long would be like approximately, if that's possible to do it, to kind of think about a time, about the time that it would take for an organization to be considered fully trauma aware or trauma informed? Is that a process that happens at once, or?
No, that's a great question. It is a process that there are some great tools out there. So let me back up there. The National Children's Traumatic, I'm not going to get this just right. It's there's a group that works between a collaboration between UCLA and Duke University called the National Child Trauma Institute, I believe. And if you find them on the web, they have an organizational assessment tool. So you could take that right now and see where you are. If today what you discern is that you're trauma curious or before, most organizations find that it's about a 3-year process to become fully trauma informed. However, I always offer, there you go, the National Children's Stress Network. Someone put it in the chat. Thank you for that. Once an organization hits the status of being able to declare we are a trauma-informed organization, my caution is don't stop the work, because this is an ongoing process. Now, usually at that point, it's organic. So it's built in, everybody's bought in, we are doing this work, so folks just kind of do it. However, if there's change in organizations, new people come in. If we're not incorporating the trauma-informed way of the organization to them through, the onboarding process, we can lose sight of that and it starts to wane. So it's actually good probably to do that organizational assessment every 3 to 5 years at least.
Thank you.
Sure.
Thank you.
I had a quick question for you, Dr. Hatcher. You said earlier, everybody has experienced trauma, so all systems are impacted by trauma. How do you help folks to move away from the trauma yes, no orientation, have it or don't, toward more of a spectrum? Is there a simple orientation that helps you to kind of shift systems and people toward thinking of it on a spectrum?
What a great question, to which I don't have an answer. But I'm making myself a note and I'm going to do some research around that. Because I do believe we all have a spectrum of this. I also want to note not only the spectrum of trauma or adverse experiences that we encounter in life, but also we're all geared differently. So how we respond to those things may look very different for the two of us. You and I may have the same experience, and it could actually just strengthen your resolve. The word these days is resilience. It could actually help you do better in life. And I have the same experience, and it actually undermines me somehow. So recognizing not only the event continuum, but the response continuum, I think is important as well. Mostly, I think that's a frame of mind that we should all just keep there. And if there's not a tool to develop, you and I should partner to create one. So.
Well, there is Philadelphia. There is a group in
Thank you.
Philadelphia that created that tool, the ACEs. They adjusted the ACEs to include adult spectrum trauma.
Yes.
And I'm going to look it up and put it in the chat because that one is actually good. And it also discerns between PTSD, which is a clinical diagnosis, and then trauma experience or exposure.
That's right. Right. Yeah. The simple fact of of having trauma does not indicate a PTSD diagnosis necessarily. So thank you for naming that. I also just want to throw a plug in. While we know that adverse experiences have in the whole population these health outcomes, it's also true that positive experiences that individuals have, particularly earlier in life, can set a stage for a very different kind of outcome. And that to some degree, we can offset adverse experiences through appropriate positive experiences.
Thank you so much. I see a question in the chat from Richard. I saw that someone is using trauma responsiveness care. Is that similar to trauma-informed care? If not, how are they different?
Trauma responsiveness care. So in the continuum we walk through in terms of the stages of development, I would say trauma responsive is it's between trauma aware and trauma informed. You're on the way to that. And quite frankly, if an organization gets to trauma responsive, that is significant and that's worthwhile. And some organizations may decide this is good enough for us and our patient population. So, yeah.
And somebody would like more resources. Sydney would like more resources that detail the process from getting from trauma curious to trauma informed.
I'm happy to, if you want to email, I'm happy to send you some resources on that. Mostly if you can just do your own research around implementing trauma-informed care, and you're going to find dozens of models how to get there. Again, I'm a fan of the trauma-informed Oregon model. They have a roadmap of how this happens, and it's part of what I like about how they do is they understand the fluid nature of all of this. They sort of wrap the humanity in it. It's not just do this and then check the box, you're done, move here. It really is has a fluidity to it, and that organic nature, which again needs to be measured constantly to keep us moving forward.
Thank you so much, Dr. Hatcher, and thank you everyone for joining the discussion. Please keep the questions coming in the chat, and in the meanwhile, we will move on to the next part of our session. Jackie, could you please bring up the announcements from Beeville, Texas? Um, we're having a bit of technical difficulty. Thank you so much. To claim your CME credit, you must text by midnight tonight. Please text 1009-5685 to 844-502-1338 to get your CME. Next slide. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and broader learning community. There is no need to prepare a formal presentation. We will provide you a case form to fill out to assist with your case presentation. Please email us at cstat@uthesca.edu. Next slide. It is that time of the year to renew our series. Following this session, you will receive a Zoom notification email with the link to be able to add to the series to your calendar. Please note that you will have to do this only once. Next slide. Please join us for the next session in our COVID-19 webinar series. The topic will be thriving in substance use disorder service delivery in the post-COVID era. And this will be presented by Dr. Brittany Houston. And please, you can find all the information using the link, and we will be posting this in the chat. Next slide. Please join us at our next Systems and Sustainability Echo. We will be discussing strategies to align addiction care with community needs. Our next session will be on Thursday, April 25th. And with that, we will move on to our case presentation. Chelsea works with an organization that engages, educates, and empowers the recovery community to make a difference for others affected by substance use. So Chelsea, please tell us a bit about your role in your organization and what are some of the challenges that your organization is currently facing?
Absolutely. So my name is Chelsea Collier. As she said, I work with recovery people and I am the Prosper Project Coordinator. And Prosper stands for Peer Recovery Organization, Sustainability, Planning, Equity, and Research. It's quite a long acronym, but there's so much to unpack there, right? Basically, what we are doing is it involves peer recovery organizations, which are everybody from recovery housing to recovery community organizations and the like, as well as payers of peer services and stakeholders. Now, with this project, recovery people will strengthen the capacity of peer and recovery organizations to drive policies, access diverse systems of revenue, and advance the integration and provision of recovery support services across coordinated state and local recovery-oriented systems of care. So to expand, excuse me, to expand the recovery support access and health equity, this is our outcome. These are our desired service outcomes. For Texans with substance use and or co-occurring mental health challenges and their affected family members, the activities will recruit recovery organizations, peer recovery support service payers, and stakeholder partners into a social impact network and to develop sustainability models and a statewide strategic plan, identify policy, knowledge, and capacity strengths, weaknesses, and opportunities and threats, SWOT, and implement solutions, for example, advocacy, awareness training, and technical assistance. our challenge right now is because of the geographic size of Texas, it makes it difficult to identify and engage the PROs, payer stakeholders from across the states. So while many people are familiar with peer specialists and services, fewer know what peer and recovery organizations are and the benefits that they provide. So I'm really coming to y'all today to ask, what are some ideas that you might have? What strategies can we use to identify and recruit PROs, payers, and stakeholders into the network and participate in our research? We have a Prosper Network membership that is available through our website that you can get signed up with. And through that, we will then contact you and we will invite you to our different learning series that we have. But also we want to really get the research done and get the data in so that we can come up with this statewide strategic plan for organizations to sustainability. It's a lot of S's. Let me see here.
Chelsea, I have a quick question that could help clarify. So what have you already tried? And how, in your grant, is there a metric for reach that you have to attain to meet the criteria or what you've agreed to do?
So it's a 3-year grant. And so overall it's 750 unduplicated people that we have to reach, right? And so, so that's really our metric. And right now we have 43 Prosper members signed up. We have 25 different organizations, which is great, but I know that there's so much more out there. I know that there's so many more people. So it's just kind of, how do we get the word out? You know, how can we get to other individuals that maybe we're not reaching, maybe the rural networks or the border counties? What would y'all suggest would be a great way to get to those communities?
And Chelsea, before folks offer up some suggestions, oh, I'm sorry, Leslie, I just saw your hand was up. Okay, all right. Do you have an equal challenge across all 3 of the areas, peer recovery organizations, payers, and other partners? Do you feel, or is there one where you're particularly interested in feedback?
More, I think for the size of Texas, we don't have that many like recovery community organizations and that type of thing, right? So what are those areas that we don't even know about? What are the up and coming recovery community organizations? The payers, we have a consultant working on this project and I think we have the payers pretty much down. But as you know, there's such a wide spectrum of payers. That could mean insurance companies, grant opportunities, other private entities that are funding. So that could be a larger area as well. But I think more the people that we just don't know about, that we haven't talked to yet, that we haven't gotten the word out, that we have this amazing resource, because every month we're bringing these amazing learning opportunities, right? Resources. This month we're going to have Dr. Sierra Castel de Martel, and she is going to present on her recovery calculator and the cost effectiveness of peer recovery support services. So we just have all these amazing things coming up, and I want to make sure that we are getting the word out, letting people know that we're here, we're here to help, but also be able to obtain that data so that we can come up with a statewide strategic plan to help organizations become more sustainable, because we want to really see them stick around. Did that answer your question? Good.
Thank you, Chelsea. Leslie.
I was just going to ask, and I'm assuming others might even have something similar, but I'm wondering if you've already done outreach to community organizations, just like you are outreaching today, and pose that so you can kind of bridge with them so that you can do online, discussions and outreach and really be able to expand. I'm just wondering if you've already, you would even mention the rural community, contacting, the rural community health centers, all of those pieces.
And we absolutely have, with recovery people, we have such a wide network already. We have so many participants that sign up to our sorry, our communications. And so we can really touch a lot of people that way. But again, I feel like there are some people that don't even know about recovery people and don't even know that they don't know what they don't know, right? They don't know that there's something there already. So we've reached out to the connections that we already have, our networks. So it's more of coming up with, I really want to come up with some out of the box ideas, of how to engage people. Zoom is great and you can really get to a lot of people that way. But I feel like, especially in those rural communities, it's going to be difficult to use Zoom, right? So it's going to be a boots on the ground, truly going there and seeing what we can find. But I think it's more of, what is out there that we don't know about.
Esmeralda?
Yes, to speak about the rural communities, I know once you target what rural community that you want to work with, because I had to do so much work with this, and you need to pull up their calendar, their community calendar, what's going on in that area, find out what kind of health fairs or who's doing what in the area, because once you find out who the gatekeeper is for that rural community, you're going to have access to a whole lot of people within that community. You'll be able to talk to different organizations in there, religious or nonprofit, the people that are in the community, community centers, they're going to open up to you. But if you're a newcomer coming in, they're going to be looking at you up and down, like, who are you and what do you have and how much is it and how long are you going to stay? Because it's like, we've had people come in here before, they've not fulfilled anything that they said, so who are you? So if you can find out who the gatekeeper is to that rural area, you're going to have access to a whole lot of individuals. But it's going to be doing a lot of footwork, passing out flyers, getting engaged into the different community events that they have in there, and start being noticed. That is the biggest thing about rural areas. And a lot of them don't have internet access, or it's very poor speed. And so you go in there with, oh, just contact me with this QR code. They're looking at you like, what the heck is that? And just make sure you have phone numbers and different ways to get in touch with you aside from internet and QR codes, so that, especially for the older community that's in those rural communities, that they have an option to be able to get in touch with you. Just making sure you have the proper flyers, information, and being able to just really come down and talk to them and speak to them at their level, because they're looking at you like you're an alien. So it's like, what do you have to offer? And we've already been let down by so many people. How long are you going to stay?
That is so true. Thank you so much for that. Those are great suggestions. I love that.
Okay.
Thank you. Kristen?
So the organization I work for, the Houston Recovery Initiative, is a ROSC, so Recovery Oriented Systems of Care. There's many ROSCs across the state of Texas. They can help connect you to the regional providers, other resources, housing, employment, food, healthcare, whatever is local to that area. The HRI has 1,000 members, and while we're mainly focused in Harris County, with the RCO there, we do have members across other counties, and a lot of people from the different ROSC attend our meetings because of how we model building that networking system. So I'd be happy to connect with you after this. We also have a project where we are expanding. We've been doing a Narcan vending machine in Galveston County project, and so we are looking to expand to whatever county wants to implement it, right, and needs it and is willing to do the work, because I recognize there's 254 counties in Texas, and we don't have the funds to send people across the state, but we can have an echo just like this to model what we have done and bring in experts from other states and bring in experts from Texas and have them come together. But And having said that, if there's counties that I don't, I always say I know a guy that knows a guy. If there's somewhere that I don't know, I would say call the health department, get connected there, find out what community organizations are active, because they may not be on social media. They may only be meeting in person. And it's kind of hard to track them down, especially because the pandemic wiped out a lot of in-person only meetings and they have not resurfaced. So that would be my first suggestion. I'm happy to connect, or you can reach out to Javier Soto at HHSC. He has a list for all the Ross in the state of Texas, and then just trickle down, find everybody.
I appreciate that. Yes. And that is something that I wanted to present was, I'll put the link in the chat for the Prosper Network membership. And if anyone is interested, please sign up. And I'll also put my email address in there as well, again, so that you can reach out to me. I would love to, absolutely, Kristen, thank you so much. I would love to get in touch with you and we can talk offline about it. I did attend the statewide ROSC meeting, and I think they're more in a rebuilding phase as well right now. And so I think I can definitely get some contacts there and some connections there to help us further this project. I just want it to be a successful project, but hear from all the people, because I feel like we can't really talk about or come up with a statewide strategic plan for sustainability if we don't have impact or input from the people that it actually affects. So I just want to make sure that everybody's voice is heard, and that we can get the resources out there to people so that they can come up with some more sustainability models that maybe they haven't thought of either, so that they can stick around for people and save more lives. And that's one of the, I see the question, I'm sorry, I didn't mean to interrupt. It says, how much do your services cost? And this is a SAMHSA supported project. It's a 3-year-long project, so it's free. Everything that I am doing is free to the public. And you can jump on the Zoom and in the training and the learning series that we're doing, and it's completely free. The membership is free. We just want to get the word out there. I'm sorry to interrupt.
No worries. Thank you.
Chelsea, thank you so much for sharing that information. I wanted to expand on what Kristen had shared, the work that is being done across the state. So HHSC, as you probably will know, manage the contracts of 39 LMHAs across the state. And the LMHAs have, most of them, as the local mental health systems, they have peer support networks and recovery programs. And they can be a good vehicle to share your information and for them to be engaged in the process and use this as an opportunity to train their own peer recovery coaches and certified peers across their services. So that may be a good way, and reaching out to HHSC's substance use division, it's another way to get the word out.
Thank you so much. And I do want to make sure that to make it clear, we're not actually providing the training for peer specialists, right? That's not what this training is. It's more around the organizational sustainability. So it's how can we, like our first module in the learning series, and I see the time and I'll hurry up with this, but the first module in the learning series was, what are the different funding opportunities out there, right? Jason Howell came out and talked about braided and blended funding. And then you've got grants, and then you've got the donations or fundraising, all these different types of funding that you could get for your organization to keep it sustainable. And so that's more around what we're doing with this project. It's not the actual workforce itself and getting people certified or anything like that. It's more of, how do we keep these other organizations around that then can provide that information, right? It's how can we get those larger recovery community organizations or training entities, how can we help them with sustainability models to help them stay around. So that's who more our reach is the organizational aspect.
That's helpful. Thank you.
Absolutely. Thank y'all.
Thank you. And I see another question from Lindsay in the chat. Do you just see certified peer specialists?
And we don't certify peer specialists. We, again, we leave that to other people. This project specifically, Prosper Project, is peer and recovery organization sustainability, not the actual peers. But I see Lindsay's got her hand raised too. So
yeah, sorry, I should specify. Do you keep certified peers on staff that are knowledgeable about like the trick? Because to me, it's an organization that's peer oriented is going to need to know those ins and outs of the peer workforce, right? To be able to help other organizations. So is that something that you guys do work, like have peers on staff that are certified and go through all the process and things like that? Is that how you're kind of modeling it?
So I'm a certified peer specialist.
Cool.
And so I can absolutely, go through those networks and get to the different recovery community organizations. And Jason Howell, who is the all-knowing man for recovery people, he absolutely has different connections as well. But yes, we do have certified peer specialists on the team. And we do have some that are in the network too.
Thank you so much, Chelsea, for bringing this wonderful case and discussing your program with us. In the interest of time, I will request Leslie to please summarize today's session.
Great, thank you. And for those who had additional comments, perhaps you can put them into the chat box right now so that we can still read them and operationalize on them as well. So just to do a quick summary, we had Dr. Hatcher speak today, which was wonderful. He also has some resources if you want to reach out, or perhaps they'll be sent in our post-session survey information as well. And the links were also posted in the chat box for folks to be able to scroll up. We discussed considering building a trauma-informed curiosity in your organization. Consider viewing that development through the lenses of stage of change, where you look at your organization moving from trauma aware to trauma sensitive to trauma responsive to ultimately, hopefully, trauma informed. We also want you to really make this an organizational decision to become trauma informed and really look at developing your policies, practices, and place to promote safety, empowerment, and trust. Chelsea had a great discussion today related to the 3-year, 750 unduplicated people needing to outreach for that grant in the state of Texas. And some of those recommendations were listed as making sure you outreach to community calendars, look at the health department, align with health fairs, et cetera, really identify those gatekeepers and start being noticed. That was really reinforced a lot, consider library, community type gatherings, et cetera. So that is my summary today, and thank you all for joining us. There's also the post-session survey link into the chat, so please don't forget to complete that so you can obtain your CEs for this session.
Thank you so much, Leslie, and thank you all again for joining today's session. As a reminder to earn CME credits, so please complete the post-session survey using the link in the chat, and also please text attend 10095685 to 844-502-1338, and this is by midnight tonight. If you would like to present a case, please email cstat@utscout.edu. We look forward to seeing you at our next session on Thursday, April 25th. Thank you and have a wonderful rest of your day. Thank you so much. Bye-bye.